Okay, so we're going to go through a series of what-if questions, and what I like to do is I like to just present these to you, and then you can stop your computer, think about it, jot down a couple of possible answers, and then we'll come back on, and I'll share with you what I think probably are the best answers. But we need to be clear about this. There's a lot of room here for different solutions. So the first one is that she starts taking Effexor, and within 12 hours she has an acute onset of anxiety. So what is this, and what would you do? Okay, this is very likely to be activation because it's anxiety. It's not mania. It occurs within hours of taking the dose. The most common thing to do would be then to go in and start treating with a tranquilizer, like Ativan, for instance, with the intention of having that override the activation. And then if she is having anxiety, it may turn the volume down on that somewhat. Okay, here's our next question. Let's say she's on Effexor. Let's say we've gotten her through the activation period, but there's no improvement at 5 weeks. I'd like you to come up with 4 or 5 reasons that are possible candidates for the reason that she hasn't responded. Okay, well, let's take a look at the possibilities. What are the usual suspects here? One of them is that actually she is starting to improve, as we've discussed earlier in the class. Her kids notice it, her husband notices it, but she doesn't because the magnitude of improvement is small, but it's clearly there. But because depression leads to pessimistic and negative perceptions, oftentimes people who are clinically depressed will be improving, but they don't really notice that. What they notice, they continue to really focus on their suffering. And so we've talked before about the use of rating scales to help her get some clarity about the fact that in fact she may actually be responding. And if that's the case, that will the use of rating scales can help her do some critical thinking and restore some degree of hope. But let's assume that that's not the issue, okay? That really and truly she is not improving. So what are some other possibilities? Well, let's take a look at them, okay? Non-compliant. And keep in mind that non-compliance can be not taking the medicine, discontinuing it, but also often non-compliance is simply not taking it as prescribed. And there are a lot of people who forget doses or they get a bit of a side effect, so they cut the dose down themselves. We're going to talk a lot more about non-compliance here in just a little bit. The wrong class of medications. Okay, well, it may be that if you continue to optimize the treatment, treat aggressively with, in this case, Effexor, you get up to a maximum dose if she can tolerate the side effects, and we have less than 25% improvement. And that's suggesting probably biochemically we're shooting at the wrong target. And so the option here would be to consider switching. And there's currently only one FDA-approved drug that treats or targets dopamine, and of course that's Wellbutrin. Also keep in mind that Wellbutrin increases norepinephrine, and Strattera, technically an antidepressant but FDA approved for treating ADHD, is a selective norepinephrine reuptake inhibitor. So those are 2 choices that we might go to. If she has, let's say, 10% improvement after 5 weeks on the Effexor, especially if you go out even a couple more weeks and it's in that ballpark, that's not enough to warrant staying on the medication. Now, if she had 30% improvement, we probably wouldn't want to stay with the Effexor and augment, add the Wellbutrin to that. Unreported substance use or abuse, and this could be, of course, alcohol. People have a lot of embarrassment and shame about that. Again and again, I've been, caught off guard completely, not even suspecting that, and people will report, well, actually, Dr. Preston, the truth is I am drinking a lot of wine or something like that. But under here, we also need to consider the use of energy drinks and coffee, tea, and other sources of caffeine. And a lot of people just think, well, this can't be a problem at all. You buy this over the counter, it's no big deal. But as we know, it can really destroy the quality of sleep. The dose may be inadequate, in which case we need to progressively increase the dose, making sure we don't knock her over with side effects. She may be a rapid metabolizer, and so it's hard to know that ahead of time. But if she has, let's say, 25% improvement, it may be that she just her liver is just metabolizing this so rapidly we get inadequate blood levels, and so it's going to be important then to consider, well, she may be a rapid metabolizer, in which case what do? You increase the dose, and you can go beyond the usual therapeutic guidelines and see if that works. And then, of course, increased psychosocial stressors is oftentimes an issue. Other things, she could be a late responder. We know because severe depression, early onset first depression in childhood, early adolescence, she has that kind of history, and also severe symptoms suggest it's more likely that she's going to respond later than sooner. So waiting somewhat longer may be something to consider. Undressed psychological issues. Boy, this is huge. I don't have to tell psychotherapists about this. This is one of the biggest problems that treatment of primary care doesn't work, because even if the medication is helpful, obviously if there are ongoing significant psychological issues, that needs to be addressed. And recent onset of a medical illness causing psychiatric symptoms. We said at the beginning, didn't look like she had any medical problems, but chronic depression, it's always worthwhile to have a person get a physical, and at the very least get a thyroid panel and complete blood workup to see if that is a factor that may be contributing to the lack of response. Okay, so what if 6 weeks into this, and we're using Effexor, and we pushed it up to a high dose, okay? And so she's taking it. We think we've ruled out all those other causes that may interfere with this. We're really, confident that she's taking the drug as prescribed, and she has 35% decrease in symptoms as rated on a depression rating scale. What do you do? Okay, what do you do? Assuming she's tolerating the medicine, if you go beyond 25% improvement on one drug and you've maxed out in terms of time and dose, then you don't want to throw the baby out with the bathwater, because what you see here is some benefit from this, and it's nothing to write home about, but it's not insignificant. And so this is where, instead of switching, it would be wise to augment, add another drug to the current antidepressant. And finally, let's talk about what if it turns out that on further investigation that she has bipolar disorder. And there's lots of ways to really ask many more questions to try to uncover this. What would be the first line or standard treatments for treating bipolar depression? Now, it's really beyond the scope of this class to go into great detail about this. It's enormously complex, as you know. But let me run through the typical first-line treatments and why they may or may not be a good choice. What you see, what you see on the screen are the 4 medications that have a track record of efficacy in treating bipolar depression. Now, how about using antidepressants along with, either by themselves or along with one of these mood stabilizers? What are the issues? Well, one thing is with bipolar 2, Symbyax, which is one of the 4 drugs up there, has an antidepressant in it. It's got Prozac in it. And so if a person chooses that drug, you're going to be treating with an antidepressant. There's been a couple of recent studies that show in treatment-resistant bipolar 2 that if you use clinically significant doses of mood stabilizers and they're still depressed, that about 25% of these people can be then treated with an antidepressant and get some benefit without there being a disaster, okay? And the American Psychiatric Association is very clear about saying that you would never use an antidepressant by itself. The risks are too great. So some of these people have bipolar 2 may benefit from this. Now, if they switch into a hypomania, that's not a big deal. I mean, enjoy 3 days of vacation or something like that. We don't have the problem about manic episodes. But this other bullet item here, unanswered question about cycle acceleration. Now, the jury is really out on this, and there are studies that follow people over a very long period of time. And during times of antidepressant exposure, there are more frequent episodes. And so we don't want to throw gas on the fire. So I think that that is reason for pause before thinking about antidepressant. But just, in summary, never to be used alone, never to be used with bipolar 1, never to be used if there's rapid cycling, and really shouldn't be used with bipolar 2 until the other options have really been addressed. How about bipolar 3? She's got a lot of episodes. I mean, if this is the truth, 15 or 20 episodes, and especially if they are episodes that are of short duration. Now, her current depression is 4 or 5 months. That's somewhat short, but especially if the episodes are 2 or 3 months, that then would suggest even more strongly bipolar 3. The big problem here is if you use an antidepressant, watch out, because this person has never had manias, and now something's happened, and they've got them big time. So it's probably much better to avoid antidepressants with this group. And if she's had a period, even one period during her life where there was rapid cycling, then again you would want to stay away from antidepressants. So let's look briefly at the 4 major choices here, okay? First off, Seroquel. Well, there's a reason that it's moving to the top of the list for the following reasons, some of which we talked about in class earlier. It's the only antipsychotic that increases brain-derived neurotropic factor. It's well tolerated compared to the other drugs. It is anti-manic, so it's kind of a safety net in case somebody, flips into a mania. It may prevent that. It's beneficial to sleep. It can really put people to sleep, but very importantly, it increases slow wave sleep, which is what you really want to do, especially in long-term treatment of bipolar disorder. The downside is, of course, metabolic syndrome, and it's misspelled on your slide there, but I think you know what I mean. And that can, of course, be, over the long run, really dangerous in terms of health consequences. Okay. What about Lamictal? Well, here are a lot of things in the plus column. The downside would be that you've got to slowly increase the dose to avoid severe rashes like Stevens-Johnson syndrome. It's not likely to cause mania by itself, but there are case reports that it may provoke mania. So it's got a lot to be said for it, but it's got some problems as well. Symbyax, let me count the ways that it's a problem. You're locked into a particular dose. You can't really manipulate the 2 drugs very easily because they're all in one capsule. It contains Prozac, antidepressant for the reasons, and a huge issue is metabolic syndrome, but in particular weight gain. And keep in mind that Zyprexa can cause between 1/2 and 1 pound of weight gain per week. And with obesity rates being higher than normal in bipolar patients, and also she's already very overweight, that would not be a good drug of choice. Lithium, the biggest plus for her would be, in addition to being a good mood stabilizer, is really protection against suicide. And I think that really argues for having that be a part of her medication treatment, maybe along with other medications. However, let's go down to the cons. You got to do a lot of lab tests. Side effects, we all know, are oftentimes difficult to handle. But here's someone who's real suicidal. You're giving them a drug that if they take a tiny overdose, it can kill them, and there's no antidote. So where lithium could be enormously beneficial, in the long run, the startup of that could be risky, especially because she's feeling suicidal. And there you go. Okay, thanks for listening.